I think we are live.
Yeah, it's almost done.
Just give me a go ahead.
We are live now, so we can start in another 2 minutes. Wait, sir, we'll request for your go ahead before we start.
Okay. We can wait for 2-3 more minutes. Huh?
Yes.
Yeah.
Okay, then I just have a quick information. Can you just share then everyone's CV? Can one person do that?
Yes.
Yeah,
Yes.
sure. Yes.
Yes, ma'am. Deepak will be sharing the screen for all the CVs.
After you finish the introduction. So that's right. Okay, so I'm not going to open the CV slide. I'm
Yes.
only the panel part. Thank you.
Deepak, you can put on the slide. We will start exactly in 1 minute.
We'll do that.
Just let me know, Deepak. Huh?
Yes, sir. Wait, sir, should we start?
Wait, sir, it is 5:15. Do we start?
नहीं हो गया अभी 70.
Wait, sir, your audio is a little low.
Okay, we can start.
Okay, sir.
Sudeep, sir.
Sana, I am audible, right?
Yes, sir.
Yeah.
Over to you, Sudeep, sir. We are good to go.
Good evening, everybody. I bring warm welcome from Zydus German Remedies. And it's a real pleasure for Zydus to collaborate in this great academic event. We have been collaborating a lot of events on embryology with ACE, with IHRA, but today I am really grateful to ACE, the Association of Clinical Embryologists, to give this opportunity to Zydus to be a part of this wonderful academic program. It is my honor to introduce Dr. Priya Selvaraj, who doesn't need any introduction in this platform. She is a well-known figure nationally as well as internationally. She has been scientific and clinical director of GG Hospital, Fertility Research and Women's Specialty Center, Chennai, which is one of the greatest fertility institute of the country. She had been widely trained in clinical and ART procedures with 20 years of experience in the field, credited with achievements in the field of ART. She had been faculty in many national and international conferences and presented papers. Her areas of interest includes fertility preservation, related techniques, and pre-implantation genetic screening diagnosis, which is currently one of the most talked about subjects in fertility. I am again honored to introduce Dr. Priya Kannan, Director Clinical Embryology, Garbha Rakshambai B. Gai Fertility Center. She had been past president of ACE, a wonderful tenure she had, and she had been actively contributing many chapters in a lot of books and very active in academics, having her contribution in a lot of national as well as international conferences. Thank you very much. And now I hand over the session to you, madam, to take us forward for today's academic agenda for the evening. Over to you. Thank you.
So, Priya, shall I proceed or?
Please.
So,
Selvaraj, please.
yes. Thank you so much for that very kind introduction, and it was too elaborate, I should say. I would now like to introduce the current president of Academy of Clinical Embryologists, Dr. Ved Prakash, who holds an MSc PhD. He's the lab director of South End Fertility and IVF in Delhi. He's been extensively trained in IVF and ICSI as well as Andrology and IVF Lab from the very famous KK Women's and Children's Hospital in Singapore. He's also undergone advanced training in IVF and ICSI techniques, as well as embryo biopsy training at Brussels. He is, of course, the current president of ACE, and he's also the founder of International Human Embryology Research Academy. He's also a very sought after faculty in fellowship trainings in ART at Amity University, as well as MSc in ART at Mysore University. His areas of interest are in vitro fertilization, right from 2PN to blastocyst formation, and any innovations in embryo culture system. So it's my immense pleasure to ask Dr. Ved Prakash to welcome everyone and to also speak a few words. Thank you.
Thank you, Dr. Priya Selvaraj, for kind introduction. So I welcome on behalf of ACE, Academy of Clinical Embryologists. This is our 5th webinar series in this free webinar series. And this time that Zydus Cadila is sponsoring this program. And we have done 4 wonderful, successful webinar last in 2 months. And very happy to inform you that we are increasing our membership slowly because of these activities now. And this time that Chennai people, Tamil Nadu people have done very good program, prepared very good program this time. And you know that Dr. Priya Kannan and Dr. Priya Selvaraj, Dr. Swaminathan, and of course our secretary, Dr. Sujata is here, who have done very good work and prepared the wonderful program. So over to you, Dr. Priya. Thank you. Thank you.
Thank you so much for that, Dr. Ved. It is now my immense pleasure to call upon the Secretary of Academy of Clinical Embryologists, Dr. Sujata Ramakrishnan. She actually needs no introduction, but anyways, she holds a PhD and an ELD, which is American Board Certified. She's the head of embryology for Nova IVF Fertility Centers, and she holds a PhD in biochemistry and molecular biology from University of Mysore. She's American Board of Bioanalysts Certified Embryology Lab Director. She has held the position of IVF Lab Director in the British Hospital Abu Dhabi, as well as at Kraft Hospital and Research Center at Kodungalur and Cloud9 Fertility. Aside of this, Dr. Sujata is a brilliant academician, as well as she's been a mentor for many upcoming embryologists. So over to you, Dr. Sujata. Kindly say a few words.
Thank you, Dr. Priya. Good evening, everybody. Welcome you all for this free webinar series. The idea of conducting such webinars is to improve or to increase participation of embryologists in all ACE activities. So today, if you look at today's program, I feel this agenda is fully met, and I would like to congratulate Dr. Priya and team for preparing this session. So with that, I'm also looking forward to a wonderful evening. I would like to welcome Dr. Swaminathan, the moderator of first session, to take over. I also have the honor of introducing Dr. Swami, who again needs no introduction, the most sought after embryologist of Gen X with around 5,000 followers. And he was the past president of Academy of Clinical Embryologists, and currently the scientific director of Santati Center for Reproductive Medicine in Mangalore. And he travels a lot to many centers, even outside the country, and has qualification from reputed institution, has a PhD in molecular biology, and he has worked in reputed institutions like the All India Institute of Medical Sciences. So with that, we would love to hear from you, Swami. Please take over.
Thank you, Honorable Secretary, remembering me my old days. I first thank our clinic president, Dr. Ved Prakash, and our dynamite secretary, Dr. Sujata Ramakrishnan, for giving me this opportunity, and my team from entire team of ACE and my friends from Chennai who consider for this proceedings. It is my pleasure to introduce today's first speaker, Dr. Jason Swine. He is the Corporate Lab Director, CCR and Fertility with 11 IVF labs in North America, Adjunct Associate Professor, Rodriguez University and University of Minnesota, former Associate Professor and IVF Lab Director at University of Michigan, He is having a credit over 60 peer review publication, and he is one among the highly reputed embryologists on this globe. And his interest is in vitro embryo culture conditions. I welcome Dr. Jason to this entire program, today's evening program. Over to you, sir.
Thank you very much. Trying to get my slides to work here. So thank you all. Thank you, Dr. Prakash. It's good seeing your familiar face as well as other familiar names and faces. And thank you all. This is a great honor to be asked to talk to the ACE group, and hopefully you all have a good evening and can enjoy this. So I'm going to be talking about the IVF lab, and specifically, can what we do in the IVF lab influence embryo aneuploidy? Obviously, we're trying to grow high quality embryos to achieve high pregnancy rates. We want to make sure that we're doing that as safely and responsibly as possible. And the topic for this really came from this paper, which is now a few years old, in human reproduction. And as you can see from the title, talking about the euploidy rate in donor egg cycles. And what they show to this graph is that the euploidy rate from donor eggs, a nice control population, differed significantly between fertility centers, and it could differ up to almost 40%. And so that's quite alarming. It would suggest that there could be potential practices between centers that was influencing the rates of aneuploidy and the resulting embryos, especially in this high quality controlled donor population. And so this gave us a reason to pause and to look into some possible causes, because in the paper it gave some suggestions, and many of those focused on the IVF laboratory, which is obviously relevant to us who work in the lab. Now, what this paper did not answer was whether these aneuploidies were of meiotic or mitotic origin. If they were of meiotic origin, that would be potentially stimulation or patient-induced, coming primarily from the egg. But if these are mitotic errors, that would suggest perhaps something occurring in the IVF lab. After all, this is where the embryos spend the majority of their time, and we know that what we do in the laboratory can be stressful if we don't pay attention to the conditions that we use. And indeed, a few years later, emerging data started coming out in the literature due to advances in genetic technology and screening techniques that gave us a bit more resolution and insight. And you can see from the titles here that there was an increasing body of literature indicating evidence that differences in embryology labs can influence the rate of mitotic errors. So something during those 5, 6, or 7 days of culture could potentially be causing aberrations in chromosome separation and segregation. And this is really kind of evidenced through mosaicism. And so you can see that from these 3 headlines: rates of mosaic embryos from donor eggs varies between IVF laboratory, and from Dagan Wells and Christina Hickman, who are very well known in the field, indicating in their abstract that laboratory culture environment could impact mitotic and not meiotic aneuploidy. So similar to that prior paper from Santiago Muñe and others in human reproduction on the prior slide, they found that rates of mitotic errors could vary as much as 30% between IVF lab facilities. And so again, this pointed the finger to possible impacts causing this during culture and embryo development. And this premise isn't entirely unheard of. Here's just a quick image from a publication in Developmental Cell looking at how cellular stress can be associated with aneuploidy. Now, this is in cancer cells or somatic cells, but the same premise could hold true in the developing preimplantation embryo. Essentially, you could have mitotic cell stressors that could lead to aneuploidy, and then there's this feedback loop where there could be other problems. But we're going to really focus on this aspect of mitotic stress leading to aberrations in chromosome separation and segregation. And so most of us know that there are a variety of common stressors in the IVF lab that we do our best to avoid or combat. And we're going to talk about some of these today, specifically osmolality, pH, some chemical stressors in terms of culture media, and then also oxygen or oxidant. And then we're going to talk about some potential other stressors in the laboratory, such as mechanical or just technical. And so really, these data led us to write this review paper in RBM Online from a couple of years ago. And so the following slides are going to be a very short summary of this particular paper. But if you're interested in more in-depth analysis, you could find that here. And so culture media is one of the first things that people think about in the lab in terms of how do we optimize embryo development? What could we potentially do better? And what could be a stressor if we're using suboptimal culture media? And most of us know that culture media has improved dramatically over the years. And so has really helped us start growing blastocysts reliably. But I think there's still room for improvement. And so this particular review now is several years old from 2013 by Sebastian Mastenbrook and colleagues. And really what they did was go through the literature and try to see if there was a superior embryo culture medium. And surprisingly, in this review, they were not able to identify that. And you can see from the quote that they did not reveal a superior culture media. And this is because there's so many variables at play and so many factors in the culture system that it's really difficult to isolate the impact of the culture media itself. And so although they did not reveal a superior culture medium, which is not surprising since this was just a systematic review, it's also important to note that they really were looking at clinical outcomes and embryo development. They did not analyze embryo aneuploidy or mosaicism. And so that's a different endpoint. And perhaps we might be able to glean a different answer if we were to look at the impact of culture media on aneuploidy or mosaicism. And there is an emerging body of literature on this. This is one of the first abstracts examining this from Dagan Wells and Santiago Meunier and others. And what they did was they retrospectively compared the rates of mosaicism between 27 clinics. And remember, that's important because mosaicism would indicate mitotic errors, issues in chromosome separation during mitotic development as the embryos are inside the confines in the IVF laboratory. And so they looked at a variety of factors, oxygen, incubator type, media, and various other factors. And interestingly, similar to those prior studies, they showed that mosaic rates could differ significantly between centers, more than 15 or so percent. And of all the variables they looked at, the only significant differences they found were between continuous and sequential culture media. Now, I do want to point out that although statistically significant, this was a 4% difference, but nonetheless, in their study, this was significant. And so this indicated that perhaps media itself, or the way the media is being used, as we'll discuss, could have an impact on rates of meiotic errors. They found no impact of other factors examined. So again, this gives us pause and reason to continue to do research and examine whether there are ways for us to improve what we do within the IVF lab. Not long after, there's another abstract here from Christina Hickman out of the UK and colleagues. And you can see the euploid rate, sensitivity to laboratory culture conditions. And this was an improvement over the prior studies in that the sense it was a blinded, prospective, randomized sibling oocyte study. So very, very good experimental design here, not retrospective. So they looked at two different single-step media versus that last study that looked at single-step versus sequential. They used a queso media with a complex protein versus a commercial single-step media with human serum albumin as the protein. They found no differences in embryo development, perhaps not surprising. There was a significant difference in biochemical loss rate. There were differences in morphokinetic timings, and relevant to this particular lecture, there was a significant difference in aneuploidy rate, specifically in mitotic errors. And so, again, this would suggest that perhaps culture media and its components had an impact on mitotic errors, although it's important to point out they did have different types of protein, and there's a growing body of literature indicating that all proteins are not the same. There are now at least a couple publications in the last few months talking about how lipid content can vary significantly between proteins. We know that complex proteins have other growth factors and items in it other than just the albumin as an HSA. So I don't know that we could say that the impact seen here was from the media alone. And also importantly, they use the same incubators to try to control for that variable in terms of temperature and gas atmosphere. But as a result, the pH differed significantly between the two media, 7.27 versus 7.14. And so I would say 7.14 is pretty low for embryo culture by most people's standards. And so again, difficult at best to determine whether these observed differences in aneuploidy were due to the culture media or some other variable in the system. And those are abstracts, preliminary studies, very, very low end, but now there are some peer reviewed, published trials looking at the impact of culture media on embryo aneuploidy. And this is one of the first from Richard Scott's group out of New Jersey in the US. And Dr. Scott and his colleagues put out a number of very well done studies each year. And so something to really pay attention to. And as you'll see, this study was done very well and is insightful. They again use a sibling zygote split. They compared two culture systems here, a single step versus a sequential. And what they found was more usable blasts in the sequential in their hands, which is not surprising. Their lab historically used that sequential system, so they were really dialed in or optimized for that particular culture media system. There was no difference in blastocyst rate. There was no difference in resulting embryo aneuploidy or sustained implantation. And so this tells us that it's not as cut as dry that a single step media will give us better or worse embryo development or aneuploidy compared to a sequential system. Importantly, they use different incubators to make sure that each media was used in its suggested and optimized pH range. And so their incubators were the same type of incubators. They did extensive quality control on them to make sure the temperatures were as close as possible between them. And as a result, the pHs were in line with what the media companies recommended. And so that may be a reason why they saw differences compared to that prior abstract where the pHs were not within the recommended range. A more recent study from Mitch Shiwi and others at Ovation Fertility here in the US and in California. And they again looked at rates of aneuploidy and the resulting blastocysts following culture of sibling zygotes. And these two single step media, Vitrolife time-lapse single step media versus Life Global. And they found no difference in rates of resulting aneuploidy. Now, interestingly, this is 43 versus 56%. That's a 13% difference, non-statistically significant, but reason to pause. 13% certainly is higher than that 4% that we heard from the Dig and Wells abstract, which was statistically significant. So this publication says no difference, but perhaps a little bit higher than one would like to see. And here's another more recent paper from Barry Bear and the group out of Stanford in the US, looking at the impact of culture media on resulting aneuploidy between a single step and a sequential. And so this was retrospective. So I would say not as well designed as the two prospective sibling oocyte split studies that we just talked about. But nonetheless, they did something unique in that they split out the analysis into female patient age, those greater than 38 and those less than 38. And in patients less than 38, they found a significant difference in the rates of resulting blastocyst aneuploidy. So this was interesting. They found no differences when they looked at the culture media in patients greater than 38. So, certainly not cut and dry in terms of the impact of culture media on resulting embryo aneuploidy. I think it's something that we still want to continue to look at and research. But the question comes up is, what component of the culture media would be causing this? What would be negatively impacting mitosis? Is there a specific ingredient or lack thereof in one media versus another? Most media are pretty similar in terms of their ingredients, and the concentrations may vary. And unfortunately, we're not really aware of the concentrations because those aren't published anymore from the commercial manufacturers. But the question starts coming up, things like lactate levels. There are media coming out now that have lower levels of lactate. Could this have an impact? Presence or absence of certain amino acids versus others. Certainly in sequential culture media, a large group of the amino acids are missing in that first cleavage step media, and then growth factors and other things. And so what those components could be remains an active area of research. Perhaps a better question that we'll start talking about is there an impact from the rest of the culture system? The medium is just one aspect of the culture system, and there's a variety of other variables that are as impactful, if not perhaps more impactful, on how the developing embryo is progressing other than the media itself. And so we'll talk about some of these other stressors. The first is going to be pH, and most of us know a lot about pH. This is set between a balance of primarily the sodium bicarbonate in the culture media and the CO2 levels of our incubators, and this is why we measure CO2. It's an inverse relationship. As you increase your CO2, the pH decreases and vice versa. And you can see this via color change if you use media that has phenol red in it. And so really we think of pH in three main stables, so to speak, equilibration, which is where you have to have your media in the incubator long enough for the pH to come down to its desired set point. And equilibration usually takes around 8 hours or more, depending on various factors like how much oil you have. The set point is going to vary by media, but this is, you want to have a stable set point, usually somewhere in the range of 7.2 to 7.35 or so. And then you want to stabilize that pH, make sure that you're not having variations for a variety of reasons. And so various methods to stabilize that pH are extremely important. Things like incubator management, not being in and out of the incubator, having enough incubators, use of oil, use of buffered media, the variety of safety approaches and safe handling methods that we use to avoid stressing the embryo. And this is important because, as we all know, embryo development can be influenced by culture media, pH. And here's a table from an abstract from 2016 from Marty Sminkes and colleagues. Pretty novel, interesting study looking at how changing pH during culture can impact blastocyst formation as well as morphokinetic timings. And really, to quickly summarize, differences in pH can impact the rates of cell division as well as the number of blastocysts formed on day 5. And there's other studies that show similar, but this was an interesting work to me. And so this is really important because we know that cells we handle in the laboratory are especially sensitive cells, specifically to pH. Things like the denuded mature oocyte, as well as cryopreserved and thawed embryos, are extremely sensitive to changes in pH. And this is why we want to make sure that we maintain a proper and stable pH to avoid stressing the cell. And this is relevant for today's topic because pH can impact the assembly of the meiotic spindle and mouse oocytes. And a similar process could be at play in the developing preimplantation embryo. And so you can see here from 2018 in RBM Online that the spindle retarded, as indicated by pulse scope imaging, does change with a change in media pH. And so the spindle obviously controlling the separation and segregation of chromosomes, this is of concern to us when we consider how lab conditions may be impacting mitotic errors and resulting embryo aneuploidy. Another stressor in the lab is oxygen. Most of us now use low oxygen culture for our culture systems, especially if we're culturing out to the blastocyst stage. And there's a lot of good reviews on this topic. David Gardner has written on this for years and years. Here's just a sample from a review in 2013 on the subject. The results of the review and analysis suggest that culturing embryos under low oxygen improves not only embryo development, but also live birth rate. So this is really why most labs now or should be culturing under low oxygen. But in terms of embryo aneuploidy, this is also probably prudent. Now, this isn't a mouse model, but it does give us a plausible mechanism for how lab stressors in oxygen tension could be possibly influencing embryo aneuploidy. This is from a very well-established research lab, Terry Holton and Pat Hunt. And what they did is they looked at the impact of high oxygen versus low oxygen during embryo culture and the impact on cell-specific chromosome non-disjunction. And as you can see, as the oxygen levels increased, there was an increase in non-disjunction events. And so essentially, if you are culturing in high oxygen, you could be causing increased chromosome non-disjunction, which could be manifested in increased mosaicism or aneuploidy. At least there's a plausible mechanism based on this mouse data. So we had done some work in our lab in Denver in 2018 and published it at ASRM, really trying to create a stress system to see if we could induce mosaicism or mitotic errors. And we did that by culturing embryos under suboptimal or non-ideal pH levels and under high oxygen. So we purposely cultured under high oxygen and reduced or increased the pH outside of optimal ranges. And as a result, using donated human blastocysts, we were able to show that our controlled levels of mosaicism were around 2.3%, which is in line with what we show across our 11 labs. And under those suboptimal conditions with high oxygen and suboptimal CO2, we increased those mosaic rates to 20%. So this indicated to us that under purposefully stressful conditions, we can indeed increase rates of mitotic errors as evidenced by increase in mosaic rates. And then the final stressor we'll talk about in terms of culture conditions will be osmolality. And just quickly, this is the measurement of the concentration of particles, really salt particles or solutes in solution, most commonly measured by an osmometer. And practically what this means is it controls cell volume. And so if you have a hypotonic solution, which is low osmolality in the surrounding solution or media, your cell will swell. Isotonic, there's no net change. If you have a hypertonic solution, which is a high osmolality, high solute concentration, the cell will shrink. And so we can see this visually most readily in our labs when we move embryos in and out of cryoprotectant solutions, moving into high osmolality, into low osmolality. And we know that if you don't do this in a controlled fashion, you can damage your cells. They can lyse if they swell too quickly, or they can be damaged if you don't handle them in a controlled fashion. And so in the lab, what this means is we want to make sure that we avoid changing the osmolality unintentionally. And so that would occur during evaporation. And so if evaporation occurs, you have a increase in osmolality, which can be damaging. And Jay Balson and others have shown that if your osmolality increases too much, really over 300 milliosmolar, that embryo development can be impacted. And so things like dish preparation, the various factors involved during dish preparation can influence evaporation. This is why we use oil overlay, but you need to be aware of the type of oil you use. Some prevent evaporation more than others, as well as the amount. The incubator type is extremely important. Dry incubator versus humidified incubator obviously will impact evaporation. And then, of course, uninterrupted culture versus sequential or culture systems that use media change, especially if you're doing it over several days in a dry incubator. All of these factors can impact evaporation. And you can see this visually in your laboratory. Here's just an example of how quickly this can occur. This was an image I took several years ago at the University of Michigan on a warm 37-degree surface, trying to maintain temperature stability during an oocyte retrieval. And they put 500 microliters of their media into this dish, Heaps buffered media during oocyte retrieval. And they didn't use oil because they didn't like the way that the cumulus cells from the oocytes would kind of stick to the oil and get caught in the interface, and it made it hard for junior embryologists to get those eggs out. And then they would have oil droplets sometimes in the cumulus cells. But as a result, you can see that even with the lid on, evaporation occurred after just 5 minutes. And so that osmolality of that media was not what it was originally intended to be. And so this is how quickly osmolality can change if you're not paying attention. And so the reason this is relevant is that osmolality could potentially impact aneuploidy. And this is, again, in the mouse model, but gives us a plausible bridge to what may be happening in the human. And as you can see, as the osmolality increased, that there was a decrease in the percentage of normal spindles. And so for every 1 millimolar or milliosmolar increase, there was an increase in spindle disruption by an odds factor of 1.001 to 1.004. So we know that it can impact and arrest embryo development if osmolality increases too much in an uncontrolled fashion, but it can also impact the meiotic spindle and, again, potentially disrupt chromosome dynamics. So we talk about three kind of main culture system impacts or stressors that could impact mitotic errors in embryo aneuploidy. But I did want to point out, again, it's not that easy to discern what could be causing these differences that we see between labs in terms of mosaicism and aneuploidy. There are other techniques we do in the lab that can be as impactful, perhaps more so. And so this is a paper from just a couple of years ago from Eric Foreman and others at Columbia University in the US and in New York. And they looked at mosaicism and the impact of the method of fertilization, meaning standard insemination versus ICSI. And standard insemination increased the rates of mosaicism by 5% compared to ICSI. And this was likely due to perhaps sperm contamination or cumulus cell contamination. But again, lab techniques can be impactful outside of pH, osmolality, temperature, culture media. So it becomes a very difficult thing to discern where the biggest impact is. And it can vary from lab to lab. It could be any one of these things, and one could be more impactful in one lab than another. Biopsy technique can actually be very impactful. This is a preliminary study that we presented last year at ASRM with Micah Beta, our lab lead in our San Francisco lab, and he looked at a couple different biopsy techniques, a standard technique, and then a new emerging technique that we called the Flick technique. And we showed that the different techniques can impact the resulting DNA quality and therefore the reporting. And so the processing can also have an impact. We've done some studies here where if you're not washing or processing the cells correctly, you can actually damage those cells, damage the DNA, which makes it harder for the genetics lab to give us reliable results. And so, it could just be an artifact of the biopsy technique and the quality of the DNA that you're giving the genetics lab that could be causing an artificially high indication of aneuploidy when the embryo itself perhaps may be itself, but may be fine, but the biopsied sample is indicating a problem. And this is more recently was just published in a peer-reviewed journal by another group, similar in JARG, showing that trophectoderm biopsy protocols could impact the rates of mosaicism. So again, doesn't necessarily impact, suggest or demonstrate that the rest of the embryo is mosaic, but the biopsy portion that they took was damaged in such a way that the genetics lab indicated that there were higher rates of or differing rates of mosaicism. So a technique in the lab that we need to be aware of. And then this is a paper from Kathy Miller and colleagues from a couple of years ago at ASRM showing that the genetics lab may impact the results, meaning genetics labs call things differently. They have different thresholds, different approaches. And so again, it may be something not dependent on the IVF lab, but the genetics lab that could be causing some of these variances. And that's why it's important that if you are looking at differences between IVF labs, ideally you'd be using a single common genetics lab to make sure that you control for that particular factor. So in conclusion, there are a number of variables in the IVF laboratory that potentially can impact embryo viability and our outcomes, and most of us are familiar with those. And we talk about the culture system as a whole, and today we talked about medium, pH, osmolality, oxygen tension, and some others. And as mentioned, it's really difficult to determine the full impact of the IVF lab conditions and the potential on influencing embryo aneuploidy or mosaicism. It could be the culture system, it could be lab techniques like insemination or biopsy, or it could be the reference lab. Importantly, what we do know is that pre-implantation embryos are sensitive to stress, and it really is incumbent on us in the lab to make sure that we consider the needs of the embryo and that we do everything we can to optimize the culture system and maintain that viability. Thank you very much.
Thank you, Jason, for your wonderful narration of the entire culture system and its impacts on the genetic makeup of the upcoming embryo. Here I have few questions. I think we can take 4 or 5 questions, I think. A question from Dr. Sangeet Dumal. The oviduct pH is around 7.5 to 7.8, but whereas embryo cytoplasm is around 6.8 to 7. So how it is optimized using culture media? Please share your opinion on this.
Yeah, so it's really important first to note that there's a variety of ranges that are quoted by people. And so it's important to look to see where those ranges are coming from. Those numbers seem a bit off compared to numbers that I'm aware of. But importantly, a lot of those numbers can be inaccurate at best because of the method of measurement. And so it's very, very difficult to measure pH in vivo. And then there can be variations based on the publications you're looking at. But by and large, the recommendation is that the internal pH of gametes and embryos is usually somewhere around 7 or 7.1 is the number that most people quote. And then yes, in vivo, the pH seems to be differing based on the measurements, and they don't necessarily line up to what we do in vitro if you trust those in vivo measurements. But the difference is, hey, we are in vitro. We do have to kind of consider the differences in the environment. The culture drop, the culture dish is certainly not the female reproductive tract. And so most people say that you want the external pH to be slightly higher than the internal pH to offset the acidification of the internal metabolic processes. And so that's why most people culture, in a broad range, somewhere between 7.2 to 7.4. And then we always recommend that you try to narrow that as much as possible. So in our lab, we usually try to shorten that to 7.25, 7.35, just to narrow it. If you want to pick a single point, somewhere around 7.3, the midpoint range. And of course, that varies from lab to lab, but that's why the pH is usually a little bit higher than the internal pH, and why it's hard to really try to completely recreate the pH paradigm that you might see in vivo.
Yes, thank you. And next question is from our Secretary, Dr. Sujata Ramakrishnan. She asks, what is the minimum time oil has to be equilibrated before use?
So good question, because it's hard. You can't really measure pH in oil, right? So it's a good question. We leave ours in overnight. If you take it out of the refrigerator, and put it on your drops, it equilibrates as the same amount of time as your culture media, so minimum of 8 hours. If you're using a isolator system where you're pre-equilibrating media separately from oil, we leave a bottle of oil in the incubator for a couple of days before it gets used. So it's really more of a temperature, and it does get permeated with gas. So it's a great question. I guess without knowing for certain, not having measured it myself, I would say around 8 hours, same as culture media. It could be potentially more because it's more viscous.
Thank you. And one more question from Dr. Varsha. Could cryopreservation itself impact the aneuploidy rate?
Potentially, right? So most people are aware of the concern with temperature on the oocyte mitotic spindle. I personally think that's a bit overblown, because we know that spindle disruption is reversible if the temperature is cooled and reversed in a controllable fashion. And most of us do our vitrification and cryopreservation at room temperature. And if you give enough time for it to recover, 2 hours or more, the mitotic spindle does recover. Obviously, we vitrify oocytes regularly, and Anna Cobo out of IVI in Spain and several others have shown that there is no increased rates of resulting aneuploidy following oocyte cryopreservation. But if not done in a controlled fashion, if you're perhaps exposing cells for too long or not giving cells long enough to recover their spindle, follow a warming, potentially you could, I think, influence a bit. But I don't think it's an extreme concern considering the high quality of our cryopreservation programs.
Thank you. And a question from Manish Ghosh. How long can be the aliquoted media used? Does storing for a longer period in aliquoted form have any influence in the culture conditions?
So I'm not sure if I understood that. How long can we use the culture media? Was that the?
How long can be the aliquoted medias can be stored for further use?
Yeah, so
it influences the culture condition.
Potentially, yeah, potentially. The storage time varies now from manufacturers. It used to be, a couple months is what they would put on their bottles, but now media companies are coming out with 6-month storage recommendations, and so that's good from a supply chain standpoint, from a cost standpoint, from a stability standpoint, and so they do have more stable components like dipeptide amino acids and things like that. So I would say go by manufacturers' recommendations. They have to pass a variety of regulatory testing, CE marks, and FDA regulations. I don't know that it's bad to have a short shelf life, but we always go by manufacturer recommendations. We've not shown anything that keeping a media for 2 months or 3 months is somehow worse than keeping it for a couple of weeks. We follow manufacturers' recommendations.
Okay, thank you. And a final question from Dr. Gaurav Majumdar from Delhi. Can culture conditions affect pregnancy loss rates?
Which rates?
Culture conditions can affect the pregnancy loss rates.
Yes. I mean, I think there's a variety of studies that show that if you, just because you form a blastocyst, not all blastocysts are created equal. And we talked about aneuploidy as one endpoint. It could be metabolic stress. And so, yes, absolutely. Improper conditions can impact embryo development as well as clinical outcomes and implantation rates.
Thank you very much, Jason. Thank you for your participation and giving and sharing your knowledge in this regard. And thank you very much from entire team of ACE and the embryologists from India. Thank you very much.
Thank you very much.
Over to the coordinators.
Priya?
Yes. Hello, everyone. So I think after that wonderful lecture by Dr. Jason Spain, we are moving on to our panel. We have the topic of the series is the current practices in embryology. We've had such a high quality lecture on whether the IVF lab influences aneuploidy. Now, it is not the only thing that we do have other steps as well. So now we wish to have some answers from various on various processes in the IVF lab, where there are about, as we have known, about 200 variables. So now we do have a panel, an esteemed panel of people with experience and expertise to give us both the evidence-based and their experience-based insights into various other processes that happens in the lab, such that whenever we do have some question or we do have a doubt, hopefully this will direct us to the right thing. Over to you, Priya.
Yeah, hi. So Priya, why don't you introduce the first three
Yes,
and then
sure.
I'll go from there. He just projected it now. Yeah, there you go.
Yes. Our panelists are they are all very well known and everybody knows them. But just to give a short intro of our panelist, Dr. Sarguna Devi. Devi is a senior clinical embryologist with more than 16 years of experience in the field of ART with HPC UK registration. She is presently the lab director at ARC chain of fertility clinics. She's had extensive overseas experience and experience in various other labs in India. She's also published various research papers in national and international conferences. Her current role involves maintenance of the protocols and also coordinating academic and research programs. And she's very keen on training and development of an embryologist. Her interest on low-cost IVF, advanced sperm selection methods, and non-invasive embryo selection for repeated implantation failures. Dr. Sasikala is one of the very senior embryologists of our state, probably of our country as well. She had her postgraduate qualification in ART from University of Nottingham, UK. She's a board-certified embryologist by American College of Embryology, medical graduate with a clinical experience in obstetric and gynecology. She's also had training and work experience in IVF labs in UK, US, and India. She's, to her great credit, is one thing that she has initiated and developed the first postgraduate diploma in clinical embryology in India, which has been successfully running for the 7th year through a medical university. She's also set up and managed many IVF labs in India, and she's the founder of Kriya Creations, which is an independent embryology laboratory facility catering to independent IVF practitioners. Mrs. Amita. Amita is a wonderful person, and she possesses about 10 years of work experience in the field of ART. She is presently the senior embryologist at Cloud9 Fertility since 2015, and she is an IFS certified embryologist. She's had various work experience from November 2013 until presently now, where she's now in Cloud9. And to her credit, she has got presentations and publications. She's co-authored chapters and also presented various posters and oral presentations in ACE as well. She did have an oral poster in ESHRE in 2017 as well. And she was of great help when we had the online, in-person, the last in the embryo biopsy workshop in ACE, and she was of great help in that as well. She was the right hand of Sujata. Over to you, Priya.
Thank you, Priya. So our next dynamic panelist is Dr. Yashoda Kiran, who is an MBBS doctor, as well as she's done her master's in clinical embryology from my alma mater, which is SRMC College. And she's currently the cluster head of embryology at Nova IVF Fertility in Chennai. And she's been working with the Nova group for the past 5 years. She's also presented papers and posters at national conferences. And she's won the Best Paper Award at Chettinad International Fertility Colloquium in the year 2015 for her work on male factor infertility and whether it's a reliable indicator for IUI and pregnancy outcome. So that's Yashoda for you. And we have Dr. Anne Margaret Mangalraj, who is a senior clinical embryologist in charge of IVF lab in the Department of Reproductive Medicine and Surgery at CMC Vellore. She comes with an experience of over 24 years in andrology and embryology since 1997, and she has several scientific publications in national and international journals. She's also been the lab in charge of reproductive medicine and surgery at CMC Vellore since 2005. She has had extensive training all over the world, especially from Sheffield, England, and Scotland and Australia. And she's a teaching faculty for MCH in reproductive medicine and surgery. And she also is the course coordinator for PG diploma in ART and also postdoctoral fellowship in reproductive medicine. So welcome, Dr. Anne. And we have Mr. R. Venkatraman, who is MSc Biochemistry, and he has over 12 years of experience in embryology. He works as a freelance embryologist at several fertility clinics in Chennai and Coimbatore, and he's got an extensive work experience both at Priya's Place, Garbharakshambigai Fertility Center, as well as Prashant Fertility Center. Welcome, Mr. Venkatraman. Okay, so we will move on to the first round of this panel discussion. Priya, do you want to give a brief or shall I just do the slideshow?
Yeah, I think we'll go straight to the slideshow.
Okay.
Yep.
Yeah, you're able to see that?
Yes. Do you want to go on the full slide?
Yeah.
Go to the view and change it. Yeah.
That's good?
Yeah, perfect.
Okay, let's get rolling. So,
Yeah.
So welcome all to this panel discussion on lab practices up close and personal. Our first round of questions. The first question goes to Yashoda. Yashoda, we are all now familiar with the fact that PGTA is not for all patients, right? So, however, male factor is being implicated in certain practices as a possible candidate. What is your opinion on this? Am I audible? Am I being heard?
Yes, you are. Can someone spotlight Dr. Yashoda?
Is she here?
Is Yashoda here?
I think Dr. Yashoda accidentally logged out.
Yes.
Okay, so Priya, we'll go on to the next question.
And then we can come back to Yashoda later on.
Yep, so let me just, yeah, there you go.
Okay. Devi is here. So, well, we all have had our own thing of the past, and now where we had differences of oxygen concentration in our embryo culture, we are used to having it at higher, but now in the decade or so, we've been having so much of publications guiding us that we probably might be better off using oxygen concentration, lower oxygen concentration. But then what is your opinion on oxygen concentration in embryo culture methods?
Thanks, Priya. Good evening to everyone. And the ultimate aim of this IVF program is getting success. Success means delivering of a normal, healthy child. So we try to imitate whatever happens in the physiology. So we try to have everything placed in the IVF lab so that we have less manipulation. So one of those important parameters is oxygen concentration present in the culture incubator, through which a culture media is attaining the required oxygen concentration. So we do see commonly two different types of incubators. One is having an atmospheric oxygen levels, that is between 19 and 21%, if you say, depending on the altitude. Generally, it's 20% oxygen. And CO2 is kept as 5 to 6%. So of late, there was a shift in the use of low oxygen levels, that is 5%, which is close to the physiological levels of oxygen, which is ranging between 2 and 8%. So the question now is, what is a higher oxygen levels in the culture? Is it detrimental to the embryos? Because we might expect a potential risk of high oxidative stress to the embryos, as well as the subsequent development of the embryo within the body. The measurement of the partial pressure of O2 in the culture is decided by the dissolved oxygen in the culture media. So there is a difference. So you may have to slightly leave the oxygen levels of the incubators set up so that you achieve the required oxygen levels in the culture media. Next slide, please. All right, so we need to see what the literature say, and there have been abundant studies done in mammalian species, but obviously, like in humans, there have been numerous studies present, but no clear conclusion as of yet made. Since early 1970s, the low oxygen concentrations being followed for embryo culture by Edwards and Steptoe. Coming to few meta-analysis and systematic review to save the time, let me just go through some. And the first one is means reported in the BMJ in 2011, where they have found no evidence of low oxygen concentration benefiting IVF culture. That's the first thing. At the same time, Cochrane review in 2012, they have supported slightly on the low oxygen concentration incubators and the culture. They said no evidence of any adverse effects from the low oxygen concentration applied to the culture media. But we have to wait until we get more reports on RCTs. As well, in fertility sterility, there was a detailed systematic review and meta-analysis by a Brazilian study, where they said they're not uncertain about whether low oxygen is giving you a better clinical outcome comparing the higher oxygen concentration incubation. What is expected in a high oxygen concentration theoretically, actually? So you're expecting it may be negatively affecting the pre-implantation stage embryo development by alterations in transcriptome, proteome, as well as there are a lot of epigenetic changes may be present. But in the animal studies and in some human studies as well, they have found no difference in the morphology of the embryo. So we see they are good.
Sorry to interrupt, Devi. I was just wondering, we have talked about the morphology. Has any of these studies, have they given any improvement in the pregnancy rates or the aneuploidy rates, or has it got any of those things?
Yes, they have. Yeah, there have been a lot of studies which are supporting this, but I've taken only the reviews and meta-analysis. So that
okay, what does the meta-analysis say about the euploidy rates in the embryos when there is low oxygen tension as compared to higher oxygen concentration?
They both are safe to use. So there is no big difference between low and high oxygen concentration.
I think that is the situation. But I had one question from what you had been talking. One is that you said that we have to measure the oxygen that is dissolved in the medium. How do you do that?
No, that's exactly not possible. Okay. As Mr. Jason Swain said, the pH is slightly kept up so that you are giving the enough
no, I was just wondering, is it measurable at all in our lab? So I had that query.
Only the pH can be done. So what they suggest is you can keep your oxygen levels not exactly at 5, you can keep it at 6, even to 10 in some of the laboratories to achieve the required amount of partial pressure in the culture.
Okay.
That's some suggestion.
You, Devi. So
I have one more slide, actually, the last one.
Oh, you have another slide?
Yeah.
Okay, you might have to be brief because...
of course, yes.
Yes.
Yeah. There have been few studies on ultra low oxygen levels also, because when in the uterine cavity, the oxygen levels is found to be 2%. So 3.5% as well as 2% of oxygen concentration being applied with the control group of 5% CO2, and they found benefit and no benefit. So the lack of knowledge on regulation of oxygen levels in vivo and their association with other nutrients, how the oxygen is utilized by the embryo is not clearly well understood. So as a conclusion, as of now, slight improvement, but no big difference between these two. Personally, I would prefer a low oxygen incubator because...
Why is that? When there is no evidence, why would you prefer?
Of course, yes, because we try to imitate the physiology.
Okay. Even if there doesn't show any difference.
You may get more evidence in the future to say no.
Okay. Yeah, we're waiting for the future evidence. Great.
Yes. Thank you.
So, Priya?
Yeah, shall I move on to the
next slide? Next question, please.
So this is for Dr. Shashikala. What are the key performance indicators to evaluate embryologist performance? How do you go about it in your lab? Dr. Shashikala is here?
Yeah, she was here.
Can you hear me?
Yeah. Yes, we can hear you.
Okay. First of all, thanks for that wonderful introduction. And I'm given a minute to finish my topic, which is humanly impossible.
Yeah, we'll give you 2.
Yeah, I'll try my best.
Thank you.
So Performance indicators are an objective way to measure or evaluate any healthcare system. And in our case, it is the ART laboratory. And we need a system to measure the lab overall and also the embryologist performance. So far in ART, there are no established PIs so far. So the Vienna consensus was convened, which was a 2-day meeting. And in that meeting, based on 2 surveys where international and national lab directors and ART practitioners participated, there was one alpha survey and a SHA survey. So based on the results of the survey and scientific evidence and their own personal clinical experience, they came up with a few indicators. There is a reference indicator, there is a performance indicator, and there is a key performance indicator. Now, the reference indicator is nothing but, the oocytes coming into the lab. Basically, only if you get good material, you can give a good product. So if the raw material is not good, you're not going to give a good product. So if the oocytes are good, the results, whatever technique you use, is going to be good. So the reference indicator depends on the number of oocytes you get. For example, on the day of retrieval, the number of follicles which are more than 14 millimeters. And how does this number compare to the number of oocytes retrieved? That should be more than 90%. This is what they said. If you get a good number of oocytes, which are M2, accordingly, your results will vary. That was the reference indicator. And then you have performance indicators. These are indicators for which you need the data to be documented and stored on a regular basis. Depending on the lab, you could decide 6 months or 1 year, whatever. Now, the key performance indicators, these are the more core of the ART lab. These are to be measured regularly for the overall lab performance and for the individual embryologist performance. I'm going to divide this into three parts. One is the andrology, the IVF, ICSI, and cryopreservation. So I'm going to rush through the numbers, but the slides are here. If anybody needs, you can take the slide. And also you can go into literature and see this is the Vienna consensus. So the sperm KPIs, you look at post-wash motility. This is the most important one because, there are different protocols and the different media used, different embryologists. So the approach to the technique, when you do the sperm count, motility, morphology is entirely different. So there's no one way you can make, a single benchmark value for this. But if your post-wash motility is about 90 to 95% of the pre-prepared sample, then you're good. So this is an important indicator on the andrology side. When you go to IVF, the basic thing is the fertilization rate. Now here the benchmark will be more than or equal to 75%, but if you achieve 60%, you're considered good enough. Similarly, polyspermy. Polyspermy should be less than 6% and 1PN rate should be less than 5%. In ICSI, it is supposed to be less than 3%. And failed fertilization cycles. Now in this, it is not about individual oocytes or individual batch. It is about a single cycle which has gone through ovarian stimulation, retrieval, and IVF. So in a complete cycle, in the number of cycles, if less than 5% of your stimulated cycles do not have fertilization failure, then you're okay. If it is more than 5%, then there's something wrong you have to definitely look into. Now, coming to the cleavage rate, you expect at least 95% of your embryos from the fertilized ones to go into cleavage. Similarly, the day 2 embryo development rate should be more than or equal to 50%, and day 3 development rate should be more than or equal to 45%. Now, I'm not mentioning the benchmark values here, those you can see on the screen. If you come close to the benchmark value, that's the best that can happen to your lab. And the blast development rate, the literature says if you get it more than or equal to 40%, it is good. But I sincerely feel now the blast rates have improved and we are nothing less than 70 or 80%. And if you look at ICSI, the most important rate, if you look in ICSI, is the damage rate. More than the fertilization rate, which we expect about 65 to 70%, where the benchmark value is more than or equal to 80%. The damage rate is the most important one. How many oocytes are you damaging when you do ICSI? That's the most important criteria you have to see. Now, damage can occur when you strip the oocyte, when you do the ICSI, or the next day when you do FERT check. All these three count into the damage rate. If you're doing a batch and you have 10 patients and you do oocytes for 50 oocytes, and then you say your fertilization rate is 60, I don't think that's one indicator which you can be happy with. What happened to the rest of the oocytes? Did they degenerate or did they not fertilize? If they did not fertilize, then what is the reason for it? So this is an important criteria any embryologist or an ART lab should consider. Here again, failed fertilization should be very, very less. And with advent of ICSI, I think failed fertilization is rare. We don't see that much, maybe 1% or less than 1%. When you go to biopsies, you should look at how many embryos you get DNA detected. So that is an important criteria when you come to the biopsies. You should have at least more than or equal to 90% of your embryos getting DNA for the biopsy. For gene detection. Similarly, in cryosurvival, they look at blastocyst survival rates, which they think more than or equal to 90% is what is expected. The benchmark will be 99% here. The last one is the implantation rate. The implantation rates, again, will differ according to your stage of the embryo. It can be cleavage, it can be blast stage, and it can be a biopsied embryo. So for all these, the rates differ. And the expected competency value for implantation rate in a cleavage stage embryo would be more than or equal to 25%. In a blast stage embryo, it should be around 35%. And in a biopsied embryo, you expect around 30%. Of course, the benchmark values again for these are still higher. So these are the important indicators you want to measure in your lab in andrology, embryology, your biopsies, and your cryopreservation. This is a way to assess whether your embryologists are doing good, or on an individual scale, whether you want to assess yourself, how far are you from the expected range, and together the lab and the embryologist and the clinician together can give better patient care and better results to the patients. Thank you. 2 minutes over?
Yeah, more than 2 minutes over. Shashi, I just wanted to have one question from you. You've stated so many, all that stuff. If you can give me, if I can ask you to filter it down to 2 important indicators, let us forget about the oocytes given to us and all that stuff. Regarding the performance of the IVF lab, our clinical laboratory, if there are 2 indicators that you would consider the most important, which 2 would that be?
ICSI degeneration rate.
Wouldn't that be just narrowing it down only to the performance of the ICSI?
No, but
how would it measure the or cover the embryo culture system? How do you think it measures the embryo culture system?
That is the ultimate implantation rate. But one basic thing is your ICSI degeneration, because nowadays I don't think any lab is doing IVF. Very rarely we do IVF cases. Most of it is ICSI. I think worldwide, not only India.
Oh, don't say that aloud on a forum.
No, that's fine. No, that's fine. I mean, you have published papers.
That's true.
Yeah.
Why do you think ICSI degeneration rate is the most important?
Because your skill is definitely a very important parameter when you see the end result. Okay. So the more careful you are with your embryos, the more the perfect you maintain it towards a physiological condition or a natural condition, the result is going to be better. So to that extent, an experienced embryologist should not have enough degeneration is what I feel. And then ultimately the other parameter will be your implantation rates, because all other parameters will ultimately end up there.
Okay. That's great. So I just wanted to ask Anne the same question. Anne, you run a big program. So which of the 2 parameters would you think are the most important to assess the performance of your IVF lab? Anne, are you there? Anne? Okay, Devi? Do you want to tell me what are the 2 important parameters for you?
Oh yeah, it's like you need to really see just one person doing ICSIs in the laboratory, or you are just seeing multiple people in multiple locations. There's a difference actually.
Yeah.
So for me, if you are getting into a blastulation, fertilization rate as well as Madam said, fertilization rate as well as the blastulation rate matters. And when it comes to oocyte degeneration rate, probably Dr. Sasikala is seeing it in a different way. What I see is like, I don't know how the eggs are given to me, and how do I see the synchrony between the cytoplasmic as well as the maturity, the nuclear maturity in the oocyte. So I may expect degeneration.
Sorry to interrupt. The assumption here is we are getting good oocytes.
Okay. Then it's the fertilization and blastulation.
Okay. So that's great. I think I would just, as we read papers, one of the most important criteria, we know about implantation, right? Finally, that's what boils it down to. The presence of the usable good quality blastocyst is probably one of the first indicators to show the performance of a culture system. And whenever that goes down, in 15 days time, we would see that there's been publications saying that they see a difference in the pregnancy rates the moment there is a decrease in the good, not just blastulation, good quality blastocysts. There were some papers like that. So I guess that's one. Shashi, there is one question for you from the participants. I would like to address that to you. How do you proceed when you are getting more M1 than M2? To proceed with ICSI or to culture them from some time? What would you do?
I would allow them to culture for some time.
How long?
2 to 3 hours.
2 to 3 hours from denudation?
Yes, because there is a meiotic inhibition factor which is released only after you denude. So if you're going to keep the oocyte in the cumulus, it is not going to go to an M2. So only after denudation, you release that factor and then the oocyte will go into M2. So after denudation, if you want to keep it for say 2 to 3 hours, that should be good enough. Or, sometimes we have kept it for 6 to 8 hours also. It all depends on your stimulation. A good stimulation should have a good cohort, uniform cohort, not even good cohort. It should be a uniform cohort. If a proper step down protocol or whatever is used and you get a uniform cohort of follicles, then this should be the normal criteria. You can have it for 2 to 3 hours, at the most 6 to 7 hours.
Thank you.
Priya, hello?
Yes.
Priya, yeah, Priya, sorry for that disconnection.
No
Priya,
problem,
can I just add up your point? I think I support on that blastulation, but all the patients we can't take to blastocyst, right?
Yes,
so we have to pick it up on cleavage stage on day 3. So we have an assessment of if you get 4 grade 1s on day 3, we are sure we will get some blastocysts, good blastocysts.
So in
that
terms
is our
of
prediction.
when you're thinking of cleavage stage transfers, what is your, if you're taking to blastocyst, a good blastocyst is a very good criteria to assess our culture system. But then there are lots of clinics, a lot of us do still cleavage stage transfers. In that, what are the 2 criteria you would put among, Shashi has mentioned so many. So what are the 2 important ones you would say are probably the most important ones which would assess our embryo culture system?
Okay.
What is your pick?
Our pick is on day 3. If I see 8 cell and plus, that is my catch, because I know embryonic genome.
How much percentage of 8 cells you want to say minimum?
At least 60%.
Okay,
because
then you think that becomes one of your criteria to assess the embryo culture system.
Because embryonic genome switches on, so we know surely they are going to be the better catch for us.
Thank you, Anne.
Actually, Anne, I beg to differ there. I beg to differ there because I really do not think the number matters for you to take it to a blast. And in our lab, we follow the quality. The quality is an important criteria at the cleavage stage for you to decide on whether you want to take it to a blast or not. Because many of our patients have minimal stimulation, and even with 2, 1, and 3 embryos, we go to blast state. And we have published a paper on it on Middle East Fertility Journal. So this is what we practice. I look at the quality.
I think just as difference in the practices.
That is just
that's acceptable.
Shashi, that was just
I just wanted to contribute to that.
Yeah, thank you.
Yeah. Priya, do you want to go to the next question?
So just, let's keep this discussion to a minimum and give some take-home points for the people who are watching as to what is your KPI in your lab. Like how Priya said, different practices, different approaches. So cleavage stage, how many percentage of embryos get to cleavage stage, and then blastulation rate, very, very important. In ICSI, there are so many technical differences, and even if you just fertilize and not do it in a great way, you know that it is definitely going to get fertilized. You have more than
Exactly.
So I'm not trying to say anything, but I'm just trying to say that fertilization part is out in that aspect. But considering that most of us are moving on to a blastocyst program, which is very essential for you to cater to your population, you have to get that kind of a program. So I have to say cleavage, blastulation, and then followed by implantation rate. Okay, Yashoda is also in right now. So do you want me to take it to Yashoda's question, opening question, or shall I move on to the next one? And take her.
I think we should go back to the opening question. That's a very interesting one.
So we're going to go back to Yashoda's question. Yashoda, are you here?
Yashoda, are you here? Oh,
yeah,
great.
I am there. Joined in.
Super. Yashoda, here's your question. You know that we're all familiar with the fact, because of the ongoing debates, that PGTA is not for all patients, but certain practices have implicated male factor as one of the indications. What is your opinion on this from your experience?
Yeah, okay. So the patients who come under the male factor are the ones who have the concentration less than 5 million per ml and all the surgically retrieved sperms. So research has shown that nearly 30% of infertility cases are due to the male factor, in whom 27 to 74% of abnormal sperms are seen, when compared to the normal men who have only 3 to 8%. Okay. So genetic testing should be advised in male factor to rule out all the chromosomal abnormalities. And one of the most common is a Klinefelter syndrome. And it is also seen that this decreased semen quality is associated with increased rates of mosaic blastocyst. So this is 6 times higher in a male factor group when compared to a non-male factor group. So the use of PGTA can help increase chances of successful pregnancies and decrease the rates of development of children with genetic defects. So the couple can have genetically their own child as well as a normal child, which is more important. And according to our data, among all the trophectoderm biopsies done, we found that 49% of the embryos were euploid. And if we see the male factor category alone, only 20% of the embryos were euploid. So this itself shows that the euploidy rate in the male factor is less than half when compared to all the other cases. So this itself shows that male factor is a good indicator for PGTA. And when the male factor is combined with the female factor, that is your advanced maternal age, the euploidy rate was 0. So hence in these categories, it is crucial to advise the patients and, you can give them the option of PGT.
Okay, just to quickly get you there. So you want to do it for a particular parameter, semen parameter, like you've mentioned sperm concentration, or is there anything else that you need to add to that?
Mainly it is just these two, ma'am, because if you see all the male factors, like if you see your the count less than 10 or the smokers, because that is like most of the population that we get is that. So we can't do in all. So we need to have a criteria. So less than 5 is where you have the maximum abnormalities. So it's better that we choose this.
Okay, I have a question for surgically retrieved sperm. So this includes PISA and TESI samples, right?
Yes, ma'am.
So what if you get a case where it's a congenital bilateral absence of vas deferens, where you know that your epididymis is nicely going to be bursting with sperms, you'll get enough and more. So I think that would be an indication, an obstructive male factor compared to
no, ma'am. In those cases, it's not really necessary.
Okay, good, because that's what I wanted you to highlight, because then we shouldn't, although this is an ongoing debate, I wouldn't say that all male factors with this kind of a criteria deserve a PGTA, because you have the other flip side of PGTA, the mosaics. So, and also a TESI sample, that's fine. But if you are going to have a much lower cohort of embryos coming from these samples, would you really think, just because of these parameters, that if you have only 2 or 3 blasts coming out of them and then the patient doesn't want to take any risk, would you still subject it to a PGTA?
We'll give the option to a patient. If they're okay to go ahead, is good. If they're not, then we can still try without a PGTA.
Okay, what was your criteria for advanced female age, that you didn't get even one euploid?
35 and above.
Okay,
oh, really?
Far-fetched, because
no, I know, Priya, I think she has combined the severe male factor plus the advanced maternal age.
but-
Then only it was 0%. That's what she says.
But sometimes I would put it as probably you can say less than 1% or something. I mean 0% is very drastic. But anyways, so
among the cases that we had, it was 0%. It was actually shocking to see it when we took the data out.
Okay, good. So when you talk about genetic testing in the male, you mean a karyotype analysis, right? And this is, so what is the other thing? So Y chromosome, Y chromosome micro, and then a normal karyotype.
You also have cystic fibrosis, any of those, if it's there in the patient, then you can go ahead with the genetic testing.
Karyotyping, like for instance, if suppose he's a Klinefelter, that's a given. What if you find karyotype polymorphisms, 9QH plus, stock anomalies, or something along with this? Would you push them for a PGTA or?
Yes, ma'am, we can give them option.
Okay, I would still say this, that if you do find those kind of karyotype polymorphisms, many of which are normal variants, which the report itself will generate and say like 1 to 1.6% is already seen in the general population. But when it is combined with a severe male factor, and probably if you get enough good quality blasts, in the sense good quality does not necessarily mean chromosomally competent, you still have to weigh the options of actually going through the biopsy or giving them whatever that you have in hand. If they haven't, if this was their fresh cycle, you understand what I mean? Like,
yes, ma'am.
PGTA might become a restricted option in the sense you have to weigh for the possibilities of all your good-looking blastocysts going for a toss. If they bring up a mosaic or a aneuploid is fine, but you do not know really if it is mosaic or that, right? So
yes.
Maybe in Priya, do you have anything else to say on that, or anybody else wants to debate on that?
I'm also as shocked as you, and as shocked as Yashoda as well to see that 0%. But then I was just wondering if you were talking
for PGTA, that's the whole thing. You know?
If you were Yashoda, I just had a small query. When you're talking about euploidy, are you talking about all the major chromosomal or the even the small satellite ones which pick up? Those are also that you tend to put them as not usable chromosome embryos, or how they all of them had major chromosomal problems, was it?
Yeah,
yes,
so
most of them did have, yes.
Yeah, suppose I have only 2 blastocysts and they come under a low risk category, the risk category that we read in the literature. So would you still offer counseling and transfer it, because that's all they have? Would you do that?
Yes, we can transfer with counseling. Yes, we can take consent as well, explain to them and go ahead with transfer if it's a low risk.
Super. Okay. Any other questions? Anybody wants to add to this?
Priya, can I say something here?
Yeah, Sujata, please.
See, when we talk about 0%, no, I don't think like we have to really be concentrating on the 0. I think what the message we would like to give from this is like the percentage of euploid embryos would be really low when there is a combination of severe male factor and female factor. So that's the message. And so now, whether would you like to advise PGT to all these patients? No, that would depend upon their number of attempts, whatever reserve they have. And, sometimes they do not want to go in for a donor embryo at all. So based on all these criteria, you make a call whether you have to advise PGT. Not that like when they walk in, you just tell them, see, you have male factor, now you are also above 35, you have to undergo PGT.
Yes.
Now, the other question which Priya asked is, like, would you still transfer them? If I had been Yashoda, I would say that it would depend on my clinical the consultant, because from the lab, I don't think we have any say on this. We only have a report which says these embryos are aneuploid. Now it's up to the consultant to talk to the patient and see whether they actually want to go ahead with this transfer or not.
For Yashoda, I am that bad consultant over here. So she should.
Thank you.
Thank you.
No, you're the good consultant. That's why you're asking the embryologist.
Thank you. So shall we move on from this, or anything else anybody wants to ask or add to this question? I think the message is very clear. The conclusions were very clear, right?
Yes. So let's go to the next question.
So this, I'm going to move it right forward. Okay, we finished with this. Okay, There you go. It's PK.
Anne. Yes, Anne is here. So vitrifying hatching or a hatched blastocyst, what are the best lab practices to improve the outcomes of a hatching or a hatched blastocyst? Is it any different to our usual blast, or is it's the same?
Okay, can I have my first slide? Okay, the recommended practice is surely intact blastocyst vitrification. Still, hatching or hatched blastocyst is not in practice yet. And I think to my knowledge, I think UK is not doing hatching blastocysts. It is still with intact blastocysts in practice with them. But some evidences, some articles have mixed opinions where human reproduction shows live birth rate doesn't have any difference whether you thaw, vitrify, or vitrify and thaw and do a frozen embryo transfers with hatched blastocysts or intact. But recent study by James et al. In 2018 fertility sterility shows there is a dip if you are doing a hatched blastocyst vitrification FETs. But recommended is intact blastocysts. Just quickly, I just want to browse through our practice. Our practice is blastocyst vitrification surely, but around 30% we do go ahead and do cleavage stage freezing. Ours is an autologous program, and we have our in-house vitrification culture media, and we do not routinely practice hatching or hatched blastocyst. Slide, please.
Okay. Dr. Anne, I thought the next one was for round 2. Do you want to present those slides as well? Right
No,
now?
my continuation of that is still there.
We'll just go ahead with that. Yeah, there you go. Is that it?
Yes, thank you. So this is just to show, I think previous slide, is it there? Sorry.
The previous slide.
That is long
It's
way to
missing,
go.
is it? It's okay. I can just continue it. I can continue it. No
Okay,
issues.
thank you.
I'm just to say, I just pulled out our 2019 data, just 1 year data, because last year COVID, we didn't have much of cases. When randomly pulled out, we just had around, let me say, around 571 blastocysts were vitrified. In that, around 16% were hatching blastocysts, which we had vitrified. It was not purposely done, but our freezing program is in the evening. So morning we graded, evening when we are vitrified, we had vitrified a bit of hatching blastocysts. And then we found, surprisingly, when we cryosurvived it, thanks for the slide, when we cryosurvived it, it was similar, whether it was an intact blastocyst or hatching blastocyst, our cryosurvival rate was similar, around 96 and 93%. But our clinical pregnancy rate was sure. With the intact blastocysts, our pregnancy rate was on higher side with 57%. When we had transferred hatching blastocysts, they had only 37%. But there is a limitation in our group on hatching blastocyst transfer, because we have a policy of transferring 2 blastocysts, but only one would have been hatching blastocyst. The other one would have been an intact blastocyst. So I can't justify my hatching blastocyst not doing well. I have my second slide. Next slide, please. Yeah, thank you. So we just looked at our clinical outcome. So I'm just running through our vitrified hatching blastocyst clinical outcome. We had clinical pregnancy of around 60%. Our miscarriage rate was 20%, and our live birth was 15%. What I want to highlight here is the 3 live births what we had, 2 of them were twins. That means 2 hatching and hatching blastocysts had implanted, but they had turned out to be a vanishing twin. Still, I cannot prove which one had gone till term pregnancy, whether it was the hatching blastocyst or the intact blastocyst. I'm still blind in that. And the next follow-up we saw was negative patients in this first FET cycles. Around 7 patients came back to us for a second FET cycle. First cycle, they all had hatching blastocyst transferred, but second cycle, we had 4 patients who became positive with intact blastocyst transfers. So this time, we just trying to say, first time we had put in a hatching blastocyst for them, they had negative pregnancy. But second time, when we had transferred intact blastocyst, we had pregnancy with them. So, and when the same time period, when we are looking at our intact blastocyst clinical pregnancy, it is around 94%. Our miscarriage rate is 8%, with our live birth 26%. So just to comparing this, both this data is just for argument's sake. We just feel better go with our, I mean, we can vitrify hatching blastocysts if you want, because our cryosurvival rate is still good, similar like intact blastocysts. Our pregnancies are occurring, but our catch is on our live birth. Our live birth, I think more with intact blastocysts is what this data is showing. Of course, numbers are very less, so limitations are on that. So I just like to say, better still stick on to our intact blastocyst vitrification. And
I would just like to ask, was there any kind of monozygotic twinning when you had these?
That was only one we got was embryonic, like we didn't get in this data, but with blastocyst we will get monozygotic twinning. So in this data we didn't pick it up. We didn't get it on this data.
I have one question for Anne.
Yes.
Can I? Yeah. So Anne, have you tried aspirating the blastocyst fluid? Have you tried that?
Yeah, like our vitrification program is, we will do a mechanical shrinkage. I didn't want to run through because of time shortage. That is our technique. We don't use laser trap. Okay, it is on mechanical shrinking. So only when we used hatching blastocysts, that will be technically be troublesome, because we will destroy it, or our cryoprotectant agent might be toxic to our inner cells.
Yes.
And next slide, last slide. Thank you. Last slide. Can I have my last slide? Okay. Sorry, next slide. Last slide.
Then one more?
Yeah. That is just my second question I'm answering. No, that is laboratory outcomes on hatching blastocysts.
You mean?
It's okay. I can just talk out. No issues. Okay. I mean, whether it is intact blastocysts or hatching blastocysts, our technique is going to be the same by vitrification. But what some places we have to be very careful is shorter exposure to our vitrification solutions, because it can bring about toxicity. And you try to vitrify only single hatching blastocysts in your carrier system. That is more maybe for a better outcome with it. And if you're a trained embryologist, does better survival rate, we can say. When we do a warming, we don't do an overnight culture, do a short culture, thaw it, transfer as soon as possible. So embryo transfer should be atraumatic, and single hatching blastocysts might be a catch if you want to do a hatching vitrified frozen embryo transfer.
And if I can just ask you some nitty-gritties about the technicalities, when you're freezing a hatching or a hatched blastocyst, you said that the exposure to the vitrification solution is less. So how long do you keep it in the equilibration, and how long do you keep it in the vitrification solution? What is the timing that you use?
Our time is a short exposure of 3 minutes. So it is like
that
1
the usual or
no, that is a normal way of doing. But in vitrification solution, we have 1.5 minutes to do it. It is like
so that means you vitrify at 37 degrees.
Yeah, we vitrify at 37 degrees.
So you vitrify at 37 degrees. So your usual equilibration solution exposure is about 3 minutes, whereas for hatched, you will keep it for 1.5 minutes.
No, sorry. No, it's not like that. It is like one whole procedure is 3 minutes.
Okay.
So I expose it to equilibrium solution for 1.5 minutes, let me say. It's like 30 seconds is on our vitrification solution. And then we take our time to cool it and then put it into our carrier system. So whole procedure finishes by 3 minutes.
Okay. Then for what is a modification that you do for a hatched blastocyst?
That's what we don't freeze hatched blastocysts.
Okay. No, when you did you reduce the time to 1 minute of equilibration and 30 seconds of vitrification? Did you do something like that, or it was the same 1.5 minutes of equilibration and 30 seconds of vitrification?
No, when we see your you have cracked your zona and you feel you're hatching your inner cell, it's coming out, we always say lesser than 30 seconds in your vitrification solution.
So, but then isn't that what the hatched blastocyst, I mean, when you do a PGT, you always do a biopsy and then your trophectoderm is always exposed. So would you say that after every PGT and biopsied embryo should be treated in the same way?
Here maybe I will not be able to answer you, Priya, because this is our in-house media and our setup is we are happy with this cryo survival rate. Let me say that.
Okay, so, if I can ask Sujata.
Priya, can I just join in here for a second?
Yeah, go ahead.
So I also wanted to bring Dr. Sujata in on this. And if, anyway, so Dr. Anne is preparing her own in-house media. That's point number one. And I think probably, though her exposure rate of 30 seconds is the same like every other media, I don't think the exposure and equilibration solution can be for all, because we use commercial. The other thing is, if we are going to say such a drastic presentation where there's a difference between intact blastocyst and hatching, all your PGTA programs are your vitrifying, hatching and hatched. So the point there is, whoever is practicing a PGTA, obviously our results are really good. There's a plus 13%, 16% jump in pregnancy rates when the cases are well indicated, number one. Second is, there is a small technicality when it comes to loading a hatched blastocyst. They say just add a little bit more of the cryoprotectant media when you're actually freezing the hatch, and also do it within, as soon as you finish the biopsy and inadvertently it's hatched, try to do it as soon as possible. And this question, I think Yashoda is going to answer in her round 2 a little bit more technical details. But because Dr. Anne is not, you're not having the PGTA program running, right?
Right, yeah, we don't do it. We don't have it.
Presented is very...
May I say one point here?
Yes, Shashi.
Okay. See, I think there's a basic difference between the hatched blastocyst and the biopsied embryo, because in the hatched blastocyst, there is no damage to the trophectodome. Okay. Maybe the cryoprotectant enters the embryo through the pores, not through a damage in the trophectodome. Whereas in a biopsied embryo, you are taking a bit of it, so there's a gap there. So the entry of the cryoprotectant and the changes subsequent to that are more than a hatched blastocyst where the trophectodome is intact.
I don't think we could extrapolate data like that.
Yeah.
Because
no, there should be a basic difference between the two.
Yeah.
Both cannot be the same.
But the one commonality I would say is that your hatched blastocyst everywhere gives you a lower pregnancy rate than your intact or hatched. That is universally agreed upon, I think. They're going to say that every PGTA program is actually causing a damage, then, it really doesn't,
not necessarily damage. You cannot compare both of them straight away. That's what I'm trying to say. There will be a difference between the two.
So we can have a marriage between CMC and the PGTA centers.
Thanks for that.
Oh, this is how we have to collaborate, because she will do all the hatching blastocyst pregnancies and tell me, and hatched and hatching, and I will do the PGTA part and give the same data, and we can compare the one which is untouched virginal and the other one which has been manipulated. So
invite us for the wedding.
Does anybody else have anything else to say? Dr. Sujata or Dr.
Sujata is here? No.
Yeah, I am there. Yeah.
Okay.
So
I was just asking Anne, Sujata, about when her correlation of whatever she's did to extrapolate that to, biopsied embryos are similar. So what is your opinion on this? What do you suggest?
So when we do a lot of biopsies, Priya, especially day 5 biopsies. And then initially, like what we were practicing was we would immediately freeze them. The moment you biopsy it, it goes into the culture droplet. And then, within 5-10 minutes, we would vitrify them. Okay, we wouldn't allow them to kind of regain its original shape or hatch.
Okay.
But then I remember some time back, not like maybe a few years back, we attended some PGT workshop somewhere. I don't even remember the faculty's name. And where I think they are from EV, they suggested that you leave in, the embryos in culture for 2 hours before you vitrify. So from our original practice, we moved on to this 2 hours in culture. Okay. So then
that
what
is
happens?
after biopsy, you leave it for 2 hours and then go ahead with vitrification.
Yeah, where they had mentioned that like you kind of, allow them to expand and then you vitrify them. Okay. So here what happens is like most of the time, it would start hatching. It not only would expand, but it also would start to herniate through the hole through which we have done the biopsies. But in both, we have not seen any dip in our survival rates, our usual survival rates, whatever it is, 98% and above, nor have we seen any dip in our implantation rates.
Okay.
If you add to that quick, okay, finish it.
Okay, but one thing what we do is we do not expose the embryos to for the normal blastocyst and expanded blastocyst would be exposed for 12 to 15 minutes in equilibration solution. We do not do that. Maximum is 5 to 7 minutes.
Okay.
And after that, the same time in
vitrification solution. That is a minute in vitrification.
60 seconds, yes.
I absolutely agree with you, Dr. Sujata. So that's 30 seconds in the vitrification solution, right? Hello?
Yeah, we can hear you now, Priya.
And then a shorter time in the ES, right?
Yeah.
Yes.
The other thing is the EV, the same people, the EV clinic, one workshop that I attended in post-ESHRE in 2017. So this was the deal, because when we asked her that, she said within an hour of biopsy, you have to, allow the blast to expand. This, we were doing it inadvertently, even when we were trained by Igenomics. But she said within an hour, you can try and freeze it. And if it is hatched, then you got to do it a little bit sooner and add a little bit more of VS when you're loading it onto your straw. These were the two hints she gave us for better survival, and also, possibly to enhance better re-expansion when you thaw it. So I don't think the 2-hour window was told to us recently, but if it's working well for you, great. But usually it's
Priya, like, what, another thing, see, the first one, what we said, like vitrifying biopsied embryos immediately after the procedure, that actually I witnessed it in Dubai, okay, where they were doing more than 100 biopsy cycles every month, mainly for sex selection, okay. I've seen the embryologist like bringing the embryo from the ICSI microscope and directly putting it in the vitrification solution. Okay. Yes, like he would just biopsy it, and even before the cells are transferred into the tube, before you do the tubing, he would place the embryo into the equilibration solution. So, and then like I'm sure the pregnancy rates are very good, especially in these cases. So I think either way, it shouldn't make a difference.
Okay. So I guess, Priya, we should move on to the next question, because it's an extremely interesting discussion. I think we can have 1 hour on that itself, but I think we have 2 more participants.
Very naughty. Let me tell you that you said we won't cross round 1. You've been very naughty. Anyways,
so I told you we won't cross round 1. That's the beauty of panels. Yes. Next question to Amita.
Amita, are you in? Amita?
Yes, ma'am, I'm there.
So culture media droplet size and how many embryos in a drop versus outcome. Can you please share with us your experience and literature, data, whatever you have?
Yeah. So it is first of all important to understand why size of culture media droplet is important. That is because of an important factor called embryo density. So embryo density is basically a ratio of embryo to culture media, and the density can be altered by changing either of the two. That is either the number of embryos per drop or the volume of the culture droplet. So several studies have elaborated and experimented different volumes of media with large volumes with 1.5 to 1 ml microdroplet culture and ultra microdroplet culture. And so density is usually considered by the embryologist as a technique in itself, but it is more rather a decision to culture embryos in group or individually, and it is protocol driven. It's based more on convenience or need to collect or maximize your data on individual embryos. So that is up to every embryologist's decision. So an extensive research on culture media have discussed pros and cons of embryo culture and large versus small volumes, group versus individual culture, single step and sequential media, and no university agreed protocols and optimal embryo density is unknown. But it has been observed that quality of the embryos increased with increased embryo density. So there are positive effects of increased embryo density, like localized buildup of autocrine and paracrine factors and buildup of embryotrophic factors, and the negative effects of increased embryo density, like increased concentration of cellular toxins and ammonia and ROS locally. And the impact of poor quality or degrading embryos on healthy embryos is again a gray area. So the main challenge for the embryologist is to provide a culture environment to maximize localized positive factors that are outweighed by inevitable negative factors. So they need to come up with a suitable protocol for culture droplet preparation or dish preparation according to our lab parameters is very important. So the current literature has extensively studied different volumes of culture media with varying number of embryos in all possible permutations and combinations. So there is a study by Dr. Jason Swain in 2012 that showed us that embryo development could be affected due to osmolality changes during the microdrop preparation method. So in this experiment, they trialed with various sizes of microdrops under different laboratory conditions. And they used two methods of dish preparation, one by the standard method where you make the droplet and overlay with oil, and by the other method called the wash drop method where you make the droplet overlaid with oil and then again replenish fresh media so that there is decrease in osmolality during the time taken between droplet preparation and the oil overlay. And they did experiment with two different temperatures, one at 23 degrees Celsius and at room temperature at 37. And the biological impact of osmolality change was demonstrated by culturing one cell mouse embryos with culture media and varying osmolality. So in the end, they found that 40 microliter of drop volume prepared by the wash drop method at room temperature showed ideal media osmolality at 5 minutes and 24 hours post dish preparation. So ideally 15 microliter of culture media droplet per oocyte or embryo, or no more than 3 to 4 embryos per 50 microliter of culture media in a flat petri dish is what is recommended. So we did a very small pilot study in 2019 in an unselected population, and the dish preparation was done by both the standard method and the wash drop method, and sibling oocytes were cultured. So we found that the wash drop method gave us a better blastulation rate compared to the standard method. So in our current practice, we use a microdroplet group culture in 60 mm flat petri dish with single step culture media, and 2 to 3 oocytes per 40 microliter droplet of culture media is what is we use, and with 9 ml of mineral oil overlay. And we prepare the dishes by using the wash drop method as explained by Dr. Swain in that paper. So having said all this, we also have to consider the type of dish that we use, the volume of microdroplets, the time taken for dish preparation. Preferably, two people do the dish preparation so that one makes the droplets and the other immediately overlays with oil. And the temperature of working surface, preferably at room temperature, no airflow. The airflow is switched off, and also the type of incubator used must also be taken into consideration. So all these factors increases pH osmolality, which thereby increases the pH and again impairs the embryo development. So from a practical standpoint, it is actually like detailed protocols must be implemented, keeping all the above mentioned parameters in mind to improve our KPIs. So that is our.
Yeah, Amita.
Yes, ma'am.
Is there any results you can share? This is a pilot study you did, no?
Yes, ma'am. So we had a better blastulation rate with the wash drop method compared to the standard method of doing just overlay, because we found that when we made the droplet and then immediately overlaid with oil, the drop kind of becomes flat, and when it is replenished, we get like a concave droplet. And because we use single step media, we feel that the results, the blastulation rates had significantly improved in our study, though it was not for a large population. We just trialed it for a few patients.
Okay, that's great. That's nice, Amita, that you presented your pilot study as well. It's very nice. But I think the key is to always understand that the embryo density in a particular amount of volume, it's very important when we look at when we are talking about ideal embryo culture system or optimizing an embryo culture system. I think that you have showed it very beautifully here. Thank you for that. I think
there's one more point I would like to add.
Yes, Shashi?
About the embryo density. She said one point that the more the density, more the autocrine and paracrine factors. I completely agree to that. but what about the nutrients when the density is more? So will the protocol change? Like the drops are changed more often, or to give enough nutrients to the embryos?
Ma'am, we just use single step media, and though we do a discharge at day 3 to increase.
No. My question is, if you increase the density, do you change the protocol, or it's the same?
No, ma'am, we did not change. We just keep it.
Okay.
Shashi, they are very clear. They put about 3 to 4 embryos in 50 microliter drop, and that's the protocol.
2 to 3 actually. Yeah.
2 to 3. So that's the
Not more than
protocol.
3.
So, and they change on day 3 as well. So I guess in spite of being a single step, you keep changing. You might as well shift to sequential.
No. When the density increases, the nutrients will be reduced to the embryos.
Then
Can I come in here? Can I come in here?
Yes, Sujata, it's your study. Come in.
So, no, the thing is, see, we don't see that's the optimal density we have arrived at. Okay, not only us, like it's based on a study. So we do not attempt to increase the embryo density. We just go by the standard density of, see, the idea is 12 to 15 microliters of media for every oocyte or embryo.
Yeah.
Okay. Got it.
Shashi, the thing is, when you put in more number of embryos, automatically the volume of the culture media increases. So the embryo density, that particular thing has to be maintained.
No, but the droplet size is the same, right? How does it automatically increase?
No, I mean,
agree to what Sujata is saying. They have arrived at a suitable amount for a single embryo.
That's right.
Fine.
So that's about it. So you don't put 10 embryos in 15 microliter drop. No, so that is a key to
Number of embryos is standard. We don't change not more than 3.
Yeah, the embryo number does not increase with the same volume. When the number increases, volume increases.
So if you have plenty of embryos, we make an extra dish for the same patient.
Yeah, that's a key.
Number of embryos.
Let's move to the next question, please. I think it was a great discussion, great point-driven, Amita. It's nice.
Thank you. Here we go.
The last question for the day. Do we Venkatraman, are you there?
Yes, ma'am. Yes,
great, Venkatraman. So, do we routinely inject oocytes with cytoplasmic vacuoles or a huge SCR and multiple polar bodies, or if you can call it multiple polar bodies or fragmented polar bodies, we don't know. How do you inject them, and what are the outcomes that you see from them?
Can't hear you. Can you hear him?
Yeah.
Yes.
Venkatraman, just be a little bit louder, please.
Okay, ma'am. Yeah. First, we see the VSCR. VSCR means vesicles in smooth endoplasmic reticulum. That means VSCR usually in M2 stage of M2 stage after the M1 and GD. The prolonged maturation caused by premature surge of LH may cause SCR formation in M2 oocytes. This one is failure of polar body extraction is also type of cleavage failure. In cases, it causes induced abnormal chromosomal configuration. Some affect refractory cells and form placental abnormalities also. Even if they develop refractory cells, and inner cell mass can further lead to cleavage failure and cause further aneuploidy embryo formation. So I have some small studies. I have got some 75 BACR positive MPM oocytes injected. The number of hurt is 37, 47.3%. Number of blast is 8, 21.6%. This is compare BACR minus oocyte. It is a lot of difference of blastulation percentage. This is 8%. Sorry, 21.6%. The next slide, please.
One question here: Do you have the background, any clinical background from which you derive these kind of oocytes, like those 15 patients?
No, ma'am. No, so randomly I take the oocytes. Some 3 patients only I got there's a number of oocytes with BACR is high. That 3 patients only I got the blastulation. That only I transferred. After
Okay.
that, yes, ma'am.
But I'm just asking roughly if you know the female factor that could have possibly contributed to this or anything, any clinical background? No.
No, ma'am. No, ma'am.
Data? Okay, fine. I'm just moving to the next slide. Yeah. And you still have to tell us how you do the ICSI on those.
Yeah, among 15 patients, only 3 patients got blast lesion, and we done embryo transfer for these 3 patients. In that one patient only got biochemical pregnancy. Other 2 patients were beta negative men. So my conclusion is BSAR. The presence of BSAR is associated with poor embryo conversion and lower chances of successful implantation.
Okay.
Then is next to go to cytoplasmic vacuoles. So cytoplasmic vacuoles is cystic fluid tracking the eggs that usually represent abnormal chemistry is differ from the VSAR. The shape is a difference from VSAR and the vacuoles. The vacuoles is very large and clearly identified. I have a small stat cell data. 2 patients I analyzed. First patient is 12 eggs injected. Number of birth 8. Day 5 embryo 5-8 cell. This one is grade 1 embryos 8-1. Number of day 5 2 blastocysts only we get. 2 blastocysts frozen 3 AB. That 2 blastocysts transfer abnormal fetus we seen in this is beta positive. In 5th month we done the anomaly scan that the fetus is some abnormal. Abnormal means his abdomen part is not clearly visualized. So just terminated, that baby is terminated. Second patient, I got the 8 eggs injected, 6 birth. Number of day 3 6. Frozen in day 3 month. That the patient frozen in day 3. 2 cycles we ship to transfer. First cycle the patient is negative. Second cycle is biochemical pregnancy. So in my opinion, in this cytoplasmic vacuole eggs, the presence of cytoplasmic vacuole does not completely block the fertilization process, and it gives normal embryo development and positive pregnancy for the some cases. So my suggestion, definitely we do the PGD for this abnormal oocytes.
Wait. The first one you said that causes abnormal chromosomal segregation events and everything, but you never suggested whether we should do PGT for that. But this you're suggesting, right?
Yes, ma'am. Yeah, that time just after analyze only we go to now plan to do the PGD.
For both groups of patients.
Yeah.
Okay.
Then multiple polar, I don't have a lot of multiple polar body injected. Anyway, yes, I give some data. Multiple polar bodies means during meiotic cell progression, unequal division take place, resulting in the large oocytes and 2 dimensional polar bodies. First polar body contains subset of bivalent chromosome. Second polar body is haplotype of chromatids. In my experience, I have injected multiple polar bodies eggs with large PBS. It will give poor embryo conversion. Some eggs only. Just I don't have statistics. 5 to 6 eggs only I injected with multiple polar body eggs, and I have injected some giant oocyte in with multiple polar body. Some embryo conversion is I seen blastulation, but that blast is grade 1 blast only. I'm not transferred to that blast. Anyway, just my studies only I freezing and thawing, and again I keep it for some more hours. It will be developing the blast, good blast. Anyway, I not transfer that blast. I throw it out.
Okay. So to quickly summarize your thing, can you just tell us which group, there are 3 abnormalities you've presented, right?
Yes, ma'am.
So this one, you said you're definitely not going to transfer. Can you just sum it up and say where you will apply PGTA if there is a good blastulation, or which you will completely disregard? Looks like you're going to completely disregard multiple polar bodies.
Yeah, for this giant oocyte or some it's a normal oocyte, ma'am.
Both.
Yeah. Is I'm not suggest to multiple polar bodies embryos go to PGD or PGS, PGTA. So directly I throw it out. This is some chromosomal abnormality also. I study some data, some paper. It's not just to transfer.
I wanted to ask Venkatraman, when you go into the Istanbul consensus, apart from the giant oocyte, neither the multiple polar bodies nor the SCR has got some significance. The other things have been taken off as abnormal oocytes or anything to be even noted in our oocytes. So even though we continue to note, so in that scenario, having said that, of course, evidence is always accumulating, so we don't know what's going to happen next. But I just want to ask you about the technique that you use when you're injecting the one with the SCR. When you, for example, let's start with the SCR. When you're talking about the SCR, how do you inject? If it's like right in the center with a large SCR, do you go below it and then inject, or do you go straight through the SCR and inject? What is your technique?
No, I inject in below the SCR. I don't disturb the that part, SCR part. I don't disturb. Just below the SCR part I inject.
What about a vacuole?
Vacuole.
There is a vacuole.
Yeah,
even if it's a small vacuole, like right in the middle of our way of fixing. What do you do?
Yeah, vacuoles just it is movable, man. In case we test that vacuole, it will be moving some place. Anyway, I push out that vacuoles with needle, then I start to inject.
Okay, so you also avoid the vacuole.
Yeah.
You don't go through. Okay, that's one thing. So I mean, the multiple polar bodies is one thing, or is it a fragmented polar bodies? You know that there's always this confounding factor, whether it's a single polar body, which is fragmented, or multiple polar bodies being there. So there's always this contention about that. So I think that's quite puzzling for all of us. We don't know which one to take. Then there are things like that. Which one do you take as your polar body? Like, which is your fulcrum to keep as a polar body when you want to inject?
It's not clear, man. Sorry.
When there are like multiple polar bodies / aka the fragmented polar bodies, how do you identify the axis at which you want to do the ICSI?
Yeah, multiple polar body means two set of polar body is correct shape and is distance from one polar body to other polar body. So that one I identify. Fragmented polar body is some one polar body. It is fragmented in itself, the nearby the space. So that one is fragmented.
You're saying that the distance between the polar bodies will determine whether it's fragmented or it's multiple, is it?
Yes, ma'am. Yes,
so then how do you, like she asked, which axis will you inject it? Is it just a...
Yeah.
How do you decide where to inject?
Yeah, it's we check the polar body is keep it that anyway we start to inject 3 o'clock question. Just in one polar body is 12 o'clock question. We inject the 3 o'clock question for injection site. So just I don't know how to say. Just we keep the injection in 3 o'clock position.
Okay.
From polar body.
Okay, so let's ask that question to a more, I mean, like another embryologist. And do you want to, when there is multiple polar bodies or like, fragmented polar bodies, Anne, are you there?
Yeah, yes, Priya.
So how do you inject? Like, which one do you take as the fulcrum at the 3 or at the 12 o'clock or 6 o'clock and then inject? What is your axe? What would be, how do you decide which way you should inject?
Our answer is very easy, Priya. Multiple polar bodies, we don't inject. Those oocytes, we don't. Even if it is a very, very large polar body, we try to avoid it. Or even if we do an injection, we try not to transfer it. That is our policy.
Okay,
but with fragmented polar bodies, we do make out. If it is fragmented, we just note it down. And after zygote evaluation, we make sure we just separated it and make it culture in a separate drop so that it doesn't join with regular good ones.
And one more question to you. What about multiple vacuoles? Do you even inject that? Multiple vacuoles in the cytoplasm?
Is that question for me?
Yes.
Yeah,
Okay.
and for you.
Okay, vacuoles we do inject, but if it is a very large one, as literature says more than 14, we just avoid it so that, but we have seen by experience, we can inject it, we are getting fertilization. Of course, embryos are developing, blastocysts are coming, but it is a not good quality blastocyst, but still that vacuole we can see even at a blastocyst stage.
And the first one, the endoplasmic reticulum, the position?
That depends. I mean, I can't clearly say on that because sometimes we do inject it, sometimes we avoid it, but it's like 1 or 2 eggs, we might inject it. If
When
the
you
same
don't have
patient.
to work on, you may as well inject it and see what comes out of
Yeah,
it.
that's what. We inject it, if it's just a few eggs for us, we can't just skip and go, right? So we have to inject it, but we try to just select the best embryo for transfer. That is up to us.
I'd like to add some my experience with SER. It's like in Europe, alpha Eshre consensus, they tell you not to inject the SER, but we still inject. There was a patient where we had SER in all the oocytes. Yeah, she had high E2 and all the oocytes had SER. And we had to inject all the oocytes because the patient wasn't happy about not injecting. We have had blastulation, very good blastulation, out of which none of the blastocysts have implanted, whatever we have transferred in the subsequent cycles. This is about one single case. And about an SER study, what I had done in a center where Dr. Sujata was already working on it, and it's her work and followed by me, where we have had SER, means embryos derived from SER oocytes being, it's like a cohort of embryos we have frozen and thawed and transferred. So it's not particularly SER plus embryos, but a cohort. And we have followed it up, and it's a very good number of SER pregnancies, and we have had good amount of live birth. There was no difference. And we followed up the pregnancy and the live birth as well. And there was no significantly, except one abnormality in the child, and there was a death. Otherwise, every other kid was healthy. That's what we understood from the cohort of SER embryos transfer.
What I want to ask you is, you said it's a cohort. So did you transfer SER plus without, like mixed embryos, or is it only these?
No, it's mixed.
It's mixed.
That is, that's what's...
You subject this kind of a case to a PGTA in case, like how you end up, suppose 80% of it is, SER, and then, you have only 20% of normal. Would you subject that 80% to a PGTA just to find out, if...
Yeah, it's very interesting to know what's happening with these SER oocytes, but
you never know what implanted, because even if you put it emits nice factors, growth factors, which might allow the normal one to implant. It's kind of like what do you call it, syngamous relationship. They say, if you were to transfer one poor quality and a good quality one, so
which is going to affect,
because it's a mixed transfer, we cannot really assess the data, but that's a very good information that you've given, that use it while you can. Simple.
Of course, yes. Yeah.
Okay. Dr. Priya, can I say something here?
Yes, Sujata.
So 2
I
points.
think that might be the last, because I think we are running short of time. Sujata would have the last word.
So no, 2 points from what like Devi said. What we did there was we kind of segregated the cases as 10% of the oocytes affected with SER. Okay, 10 to 50% of oocytes affected with, and then more than 50% of the oocytes. Okay, so when we segregated like that, we found that in the group which had like more than 50% of the oocytes with SER, the pregnancy rates, the implantation rates were significantly lower than in a cohort where, just the one oocyte is having SER from 10.
Correct.
Okay, that is one thing. So, and the second thing is like with my experience in Cloud9, like if the patient has all her oocytes affected with SER, then we take a consent from the patient telling that like we are injecting these oocytes and then we'll be transferring this. And we explain to them what are the implications, and then they're okay with that.
Okay. Okay, great. That's really interesting. I've also learned. And what about PGTA in these, Dr. Sujata, quickly? PGTA, would they be subjected to it?
10 seconds, Sujata.
No, For SCR alone, I don't think it is warranted because, like there are controversial evidence. But I don't think that is just an
You do have, okay. So it depends on the percentage that you.
Yes.
Okay. Priya, you want to sum it up and.
Yeah, I guess we've had a great session. We wanted to have it for an hour. We had 2 sets of questions ready, but I knew that the discussion there's so much to learn from each panelist that the discussion always takes it that even to finish one set of questions always is difficult because there is so much to learn from all of you with different types of technique, different methods, different ways of doing things, and so much of your pilot studies, your in-house studies coming up and throwing light on so much of scientific data and information. It's just been a lovely, beautiful one hour of panel, and thank you so much. I think I have learned so much from all of you. I think I can say on behalf of Dr. Priya Selvaraj as well that it has been the same for her as well. So thank you so much to all my esteemed panelists for sharing all your data, your knowledge, and your experience with us. Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Sujata.
And just to sum up our evening, I would like to thank ACE, Dr. Ved and Dr. Sujata for having your program here with us in Chennai, Tamil Nadu. And I would like to thank Dr. Jason for giving such a wonderful talk, to all the panelists, and of course to Zydus for giving us the technical support, to Dr. Priya Selvaraj for preparing such elaborate questions for the panel. You've worked through and through for this, so thank you so much. So I was just a bystander, just looking at her and saying hello to her. So she did all the work, so thank you so much. And it's been a great evening with so much of knowledge being shared. Thank you so much. And I guess that has been the fulcrum and the objective of ACE at all points of time, to have high quality academic sessions, and we always keep to that at all points. Thank you so much, everyone, from all for participating, and definitely the participants, not to forget, for being there and for making this program a grand success. Thank you so much.
Thank you.
Thank you, Priya.
Thank you, Priya, and thank you, Priya.
Sure. Dr. Swami is already working on it.
Swami works only on picture. Yeah, I'll post it. Thank you.
Thank you.
Thank you, Chennai.
Thank you.
Thank you.
Thank you, everyone. Thank you. Thank you so much.
Thank you. Thank you.
Thank you.
Yeah. Thank you.
Thank you,
Thank
sir.
you.
Thank you all.
Thank you.
Thank you very much. Wait, sir, I'll end it.
Thank you.
now.
Thank you.
Thank you.
Thank you.
Okay.